Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindicocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today I'm joined by my good friend and colleague, Dr. Rishi Singh, who is the president at Cleveland Clinic Martin Hospitals in Florida and incoming chair at Massachusetts Eye and Ear Infirmary at Harvard School of Medicine. Welcome, Rishi.
Thanks, Arshad. It's a pleasure to be here.
Rishi, the timing couldn't be better. You just were announced as the chair of Mass Eye and Ear, a very old and very respected program in the world, and nobody better to lead it than you. And I'm very excited today to discuss current and emerging treatment options for improving outcomes in patients with diabetic retinopathy. But Rishi, before we get started, we always ask our faculty the questions about how did they end up in retina. So yeah, tell me how you ended up doing retina and now being the chair of Mass Eye and Ear. Quite a journey over the last 20 years that I've known you.
Yeah, it's quite a journey. I couldn't have told you I'd be here now 20 years ago from where we started from. But my foray into ophthalmology was actually through cornea research initially, and I realized there was very few therapeutic options available for patients. I was doing research at the time, took a gap year in medical school. My wife got very afraid that I wouldn't return to medical school, I think, and I did, and I finished up. And I just realized that there was so much innovation, and your career has also done the same, Arshad, about looking at innovative ways of curing blindness in patients and helping patients. And through translational research or research that's clinical research, both of us and have worked on this aspect of trying to improve clinical outcomes in our patients. And so my research in the past couple of years is focused on big data research studies, clinical trial advancements, much akin to yours, and really trying to help develop the next generation of therapeutic options for patients, which we didn't have 20 plus years ago. I mean, imagine when we started out, we were the first to probably inject anti-VEGF. We were still in the PDT era when I was a resident and fellow, still doing macular laser photocoagulation for some patients. And look at where we come to. And such a great, story, I think, for any field in medicine to see 20 years change and transition it so drastically for patients. And, it hits home to close to home to me, actually, to be honest with you, because my dad has AMD. He gets injections once every few months from his practitioner. And he's lost vision in one eye from AMD. So really, it's been something that's come 360 for me in many, many ways.
Wow, what a great journey for you. And I agree with you. I don't think any other field in medicine has seen so much advancement over the last 2 decades, and obviously a lot more to come. But one more question, Rishi, will come from our listeners, especially young physicians who are going into academics, and you have had an amazing journey starting, like 20 years or so ago, or even less, and becoming a chair. What advice can you give them in terms of, going up the ladder in academics?
Yeah, I think, it comes down to just finding your passion and your passion projects, right? So you could go to somebody and say, "What should I do?" And they'll hand you something, and you'll not be so interested in what they handed you, maybe. You can also be very passionate about what they gave you, or find your own passions in that area. And that's what I've been able to do, is find projects of mine that I've been just so excited about, whether it was initially Epic, and that sounds really boring to people about doing EMR integration, but I was one of the first to integrate Epic for ophthalmology, then going on and doing clinical research and clinical studies and big data research studies. We were the first really to establish a large data repository Cleveland Clinic with all the data that we were collecting on patients longitudinally, and have one of the longest databases, including both imaging and clinical data in the world, probably by now. And then, when I went on to the hospital medicine side, which is the past couple of years, it's just been an area where I've grown a lot, learned a lot from others, other fields of medicine for that matter, and had to have like really crucial conversations and difficult conversations sometimes, and negotiating with factions about various issues. And what a wonderful way to kind of find, again, another passion of mine, which is that I love to get everyone on board and get to yes together, and really work together as a team. And hence, that's why this next role for me is going to be a return to many of the things that I really valued in my passion. All of us could be doing different jobs in the world, right? We could be probably working, maybe making twice as much or three times as much money sometimes when you consider what's out there. But in reality, it's really about what brings you joy, what brings you happiness, and what you feel fulfilled with, because that's more worth sometimes than anything else that's out there right now.
No, very well said. I think I see you as a leader, getting people together, and you have tapped into so many different aspects of retinal research, right? As you said, from big data to AI. I see you educating fellows, physicians for last 2 decades, and you have been a role model for many of us, including myself. So it's great to have you, Rishi. Quickly, tell me your favorite hobby before we dive into the details of management of diabetic retinopathy. What does Rishi Singh like to do outside work?
So Rishi Singh outside of work used to love to play a lot of golf and tennis. In most recent years, it's been hectic, so I've slowed that down. Quite honestly, these days it's about enjoying our property and our backyard, and just relaxing because of a lot of some setbacks and issues. But I'll get back to tennis and golf at some point. I just need some more time. But it's been a hectic few couple months to a year now, and I need to get back to my hobbies again.
No, I think it's important to keep the hobbies. And yes, I love to learn golf from you. I live on a golf course, but haven't golfed yet. So yeah, I think we all need to find time to do things we like to do and learn new things. So that's great. Okay, so let's go into diabetic retinopathy, a topic that's close to your heart. It's a disease that progresses over time, but for some reason in the retina space, we don't like to treat until we get to proliferative diabetic retinopathy. Tell us, over the last 2 decades, what has changed in terms of landscape for diabetic retinopathy? And we do have treatments. How come we're not utilizing those treatments?
Yeah, so it's great to see the innovation in diabetic retinopathy and DME management, right? Both of them are hand in hand, and we've obviously gathered and benefited from anti-VEGF therapy. I think that the idea that we just choose strictly anti-VEGF options for patients doesn't always work out for this patient population, unfortunately. This is a patient population, as you know, working age, lots of interruptions in care. I think to myself, like, I'm in that age group now of that 40 to 70-year-old diabetic patient. It's hard going to appointments and to getting into a doctor's office, and then knowing that's going to be 2 to 3 hours and the shot is involved and everything else. If there was a durable option for some of these patients, I think they probably would choose it. But we know the most durable option is really panretinal laser at this point for those patients who have the disease. And so hence we've sort of regressed to that. I would say that the way I've approached diabetic retinopathy and sort of the state of the art method now is a combination of both anti-VEGF and PRP. So it's anti-VEGF to stave the patient off from DR complications, whether it be neovascular glaucoma or whether it be tractional attachments, and then with close follow-up and PRP thereafter. And that to me has been the most successful in my hands. I've been able to work with patients now and really establish kind of that need for, dual therapy in patients. So it's not just one or the other. I would love to say that, a protocol S-like format would work in all of our patient populations. It's just simply not able to practically with the options we have right now. Now, thankfully, if you have an option that may be coming in the pike that would be 6 months or even up to a year, then maybe the paradigm changes. Maybe patients don't necessarily wait till they get these complications developing, because that would be ideal for many patients. Maybe the answer is we do vitrectomy on all patients and elevate the hyaloid. I mean, we've talked for many years about the fact that the hyaloid face is such an important aspect of DR development, and that in places like Japan and others, that hyaloid removal in early diabetic retinopathy is one of the keys to success in the outcomes. But we just haven't moved to that level yet because it's highly interventional and highly, fraught with complications and so on and so forth. So there is that aspect that we're always worried about in the patient population group. But I think where we are right now is a nice in between both therapeutic options, with the idea that obviously if you have more durable anti-VEGF options or other MOAs, that we would consider using those as well.
No, that's a great overview, and I'm doing similar to what you are doing. Stabilize PDR with anti-VEGF followed by PRP. Now the question becomes, Rishi, is moderate to severe NPDR. Are you treating that patient population? As we have anti-VEGFs approved for that, and we know, if you are severe NPDR, almost 50% chance of progressing to PDR over the next year or two. So we know these patients are going to progress, but most of us, including myself, are not treating moderate to severe NPDR. What about your practice?
So I think a couple things you just brought up, which are so key, right? So first, the classification scheme almost needs to be redone at this point. High-risk PDR doesn't really exist anymore in our categories. We just say it's PDR or not PDR, and we treat PDR based upon laser or anti-VEGF therapy. And if it's high-risk PDR, it really doesn't matter to us. We just go ahead and progress and treat it because we don't want the complication effect. So that in itself is one. The second is around severe NPDR, and I agree with you. I think that I do have the conversation with patients about trying to treat for a severe NPDR, knowing that, the studies like Panorama showed almost a 70% decline in the complications in those populations of patients who had severe NPDR. So why wouldn't we try in a very systematic manner with these patients who have very significant disease? The true answer is that we just haven't convinced enough patients nor providers to do so. Now, I'm convinced as a provider, it's not necessarily me per se, but it's the patient. And the way I've been able to titrate it, if I do get a patient, I have had patients who have had really convinced me with the options of getting anti-VEGF, is I take serial fundus photographs, and I take the fundus photographs to really show and educate the patient that I'm improving the DR, but also for me to kind of monitor and look at, peripheral hemorrhages or lesions that are high risk that are present there to see if they're regressing. Sometimes there's like an early, non-foveal proliferative island that can regress over time. Just following those very closely with photographs is very helpful. So I tend to use photographs as my method. And I think that that's part of the issue, Arshad, is that we don't have, very good endpoints to follow. Because if we did, then we'd be all doing it. But inevitably, we don't have an endpoint to follow in severe NPDR other than just continual therapy. And I think that that's sort of our limitations of what we have right now.
No, that's a really good summary. I think the point is that we need better agents in terms of durability. And then we all believe that anti-VEGFs work really well, and we would all like to treat moderate to severe NPDR, but I think it's not practical, as you mentioned, with this patient population. But yeah, there are some scenarios too, right? Like if somebody had fellow eye PDR, and then now they've seen moderate to severe in the eye we are looking at. Maybe that's an option to kind of intervene sooner than they get PDR. So I think the scenarios are there, but I agree with you. I think having better options and options that can last 6 months or longer would be ideal. So let's talk about three different options that are currently in development or recently approved. The first one is obviously the port delivery system. It was recently approved for the treatment of diabetic retinopathy based on the Pavilion study. Obviously, it's a surgical procedure, and this is a patient population with relatively good vision at entry, and that's why we are not treating these patients, because they don't have symptoms at times, but we know the disease is going to progress. So, Rishi, there are different treatment options that are currently available for patients, obviously, and one of them is port delivery system, which was recently approved for diabetic retinopathy. Can you share with our audience the top line data from the Pavilion study and how port delivery system fits in your treatment algorithm?
Yeah, so Arshad, obviously we have the 2-year data now for the Pavilion study. This is a well-designed study that looked at port delivery system versus standard of care therapy for patients. And this delivery platform essentially maintained 80% of patients with greater than a 2-step DRSS improvement through week 100, which is, I think, very, very impressive. And those patients who developed vision-threatening retinopathy complications and center-involving DME were very low through port delivery system in the Q36-week arm. So, what we've learned at essentially is that 9 months of this delivery platform is a very effective way of treating these patients and very low interventional way of treating these patients. I can say that I haven't done a port delivery system implantation per se. I'm going to start, I think, given some of the data and also given the changes in the platform. I think it's very important for people to understand that the initial platform for port delivery system and the newer generation platform are two very, very different devices in regards to the septal kind of alignment and what they've done as far as a configuration, as well as potentially the ability for it to, be done much easier than ever before. I know that there was in the first generation of the implant, and maybe you had a little bit of experience. I'd love to hear your thoughts on it. Very hard to introduce the needle in an office-based setting. Now in the newer setting and newer device, there's a lot more ease in doing so. But love to hear your thoughts on the newer device and kind of what you found in clinic so far.
Oh, yeah. I mean, I think it's been quite a learning ratio over the last 10 years that I've been involved with the program. And I totally agree with you. The newest port delivery system, obviously, in lab testing showed that the septum dislodgement risk is essentially zero, which was a complication that led to the voluntary recall. And number two, refill exchange procedures are done in clinic, and then having that new needle with siliconized tip has actually really changed how we are able to do this with ease, as you mentioned. So yeah, it's much easier, obviously, than what it was, and the surgical refinement and technique has really evolved over the last decade. Obviously, these patients don't have symptoms, moderate to severe diabetic retinopathy in most cases with good visual acuity. So it's a risk benefit discussion. And I had several patients who actually signed up for this study, Rishi, and I was surprised how happy they were, just like DME and neovascular AMD patient, and their fellow eyes progressed and they were getting injections. So I have patients who want to get it in the fellow eye because they see the value. So I think from a patient perspective, obviously it's important to see the benefit and a patient happiness when it comes to port delivery system. But since it's a surgical procedure, we need to discuss the risk and benefit and make sure the surgery is done appropriately and following the instruction for use. But it does prove, as you said, that anti-VEGF are very potent when it comes to controlling diabetic retinopathy. And here with 9-month refill exchange, as you said, approximately 80% having 2-step improvement. Pretty impressive, isn't it?
Yeah, absolutely. And I think, where this fits into our paradigm is trying to talk to patients and get them early on to buy into the fact that, this is good for their own therapy long term, right? 9 months is not that difficult to monitor or maintain these patients on. It's better than the 6 months of the AMD kind of study, even though, probably many of those patients go out to 9 months as well. But it's been a really great opportunity for us to treat patients differently.
Yeah, and I think it's a good proof of concept for the benefit of sustained delivery in patients with retinal diseases. And obviously, we're discussing diabetic retinopathy. So, Rishi, another paradigm shift would be to have gene therapy for diabetic retinopathy. So, ABBV-RGX-314, as we know, is in subretinal programs for neovascular AMD in pivotal stages. They have shared phase 2 data on suprachoroidal one-time in-office delivery of ABBV-RGX-314 for diabetic retinopathy. What are your overall thoughts on like gene therapy for the treatment for retinal diseases, especially diabetic retinopathy? And can you please share some of the recent data from the program with our audience?
Yeah. So again, gene therapy, another opportunity to kind of introduce long-term treatment to our patient populations. Obviously, there's multiple different ways it's being tested right now, as you're aware: subretinal, intravitreal, suprachoroidal. Intravitreal appears to be a little bit less safe because of the concerns around some of the inflammation issues, though some capsids are different than others, so it's not always universal. Subretinal appears to be the most immune privileged. Again, the problems with that are that it's a surgery and it's significant. And then there's suprachoroidal, which may be the Goldilocks, best of both worlds phenomenon here, which is that you can deliver it to the suprachoroidal space, which is a very nice gene reservoir, and hence could then lead to a positive outcome in patients. And what was studied in the trial was that in the phase 2 study with 1 year results, that dose 2, which was the kind of the middle dose that was tested in the trial with patients with baseline NPDR, that 100% demonstrated stable or improved disease severity. 70% of patients achieved any disease improvement versus 25% in the control, which was standard of care therapy here in those patient populations, and 0% worsened 2 steps versus 37% in the control group. So again, very protective effect in those patient populations. And the number of VTEs was far, far lower, like, 5, 6-fold lower in the ABBV RGX-314 arm compared to those patients who are in the control arm. So what we have found essentially is that suprachoroidal delivery can work in this population, that it can achieve really great outcomes, that it's a definite opportunity for us to treat patients differently in a very different fashion. It gives you office-based therapy, which is fantastic because these patients, obviously, any diabetic patient may have complications or issues. So it really keeps you out of the OR for these patients, and just really optimistic about what could be done here, not only with this treatment approach for suprachoroidal, but it could be multiple different drugs that are tried suprachoroidally with the gene therapy approach.
No, that's a great summary, Rishi. And I agree with you. I think very exciting to have a one-time treatment that's done in clinic. As you mentioned, I think in-clinic treatments are obviously preferred because we are able to address a much larger patient population. But obviously, we need to run a phase 3 trial that should be upcoming in the near future. And we'll see how this treatment, works in terms of efficacy and safety. Obviously, safety has been a question with gene therapy, and as you said so eloquently, that suprachoroidal space it may be the perfect place to deliver gene therapy for diabetic retinopathy. So I'm looking forward to obviously participating in the phase 3 program, and then we'll see what that shows in the next few years. And the last one I want to discuss is obviously TKIs. So you and I have been involved with TKIs with multiple programs. We have seen the efficacy in neovascular AMD. We have seen data from EYP-1901 in diabetic macular edema, and then we have seen diabetic retinopathy data also from both programs. Specifically here, let's talk about OTX-TKI because they plan to take the program forward in phase 3. So this is obviously early data that we have seen from the phase one Helios study. So tell our audience a little bit about your take on TKIs and some of the summary from the phase one data from OTX TKI diabetic retinopathy study.
Sure, sure. I mean, there. Just to be fully transparent, I think there are multiple promising TKI programs out there, all slightly different from each other from regards to their kind of platforms. Obviously, some being a reabsorbable implant, or some being a therapeutic suspension of the drug, which is there and present for patients. And the Helios phase one study was patients who had moderate to severe NPDR without center involving diabetic macular edema, and they're followed through week 48. And in the study, basically 23% of patients in the OTX arm demonstrated two-step improvement, 46% demonstrated a one or two-step improvement, and no patient developed PDR or center involving DME or vision-threatening complications through week 48. So this was studying a population at risk, obviously, of developing these complications. You can see that the drug was very, very safe and obviously effective at reducing the progression. And again, if given the alternative between this and maybe an anti-VEGF, this would be another option to consider. We also have data from the Verona trial, which had clinically meaningful gains in visual acuity, which was interesting to see. A little different as far as looking at some of the endpoints in regards to progression of disease. They didn't look at that yet. I'm sure it's coming out in forthcoming studies, but two very exciting programs already in the DME realm, with the third one going to start to work on that as well, though nothing has been published or put out to date.
Yeah, no, I think that's a great summary. Diabetic retinopathy with OTX TKI, I mean, one injection and, you're not getting regression like we get with anti-VEGF every other month, as you mentioned earlier from the Panorama study, but that's still a pretty impressive number, right, Rishi? And in terms of not having vision-threatening complications. So I think this is something that will be adapted, in my opinion, if it's approved for moderate to severe NPDR, because I don't think our diabetic patients will mind getting an injection every 12 months. Obviously, this is being studied in neovascular AMD for every 6-month dosing, but for DR, maybe once a year injection. I mean, is that meaningful for your patients, Rishi, once a year injection?
Once a year would be like a godsend, and it'd be easy to explain to patients, right? I mean, it's like, when we have the current therapies right now, when the Panorama data came out, I became very excited about treating patients with DR. I mean, I would have them on monthly dosing essentially for the first 3 months, and then eventually go to every other month and then every 3 months. I never went beyond every 3 months because fear of like not having the data set to kind of validate that, though some of the 2-year data, obviously from the study, kind of validated some of the extended dosing of even up to every quarter. But we never went as long as we're doing now, which I think is valuable. So the goal, I think the good news is that we have lots of different options to consider for these patient populations.
No, I agree with you. I think with current anti-VEGF with the aflibercept, maybe we can go 3-4 months, as you said, but going 6 to 12 months would be ideal. So yeah, let's see. And then obviously EIP 1901, the DME data from the Verona study, as you mentioned, is very exciting, and hopefully they take that program forward so we can evaluate EIP 1901 for diabetic macular edema. And in that study, I would think that if we can, obviously give something every 6 months, that's also a big achievement. So, all right. So great, exciting times for diabetic retinopathy. Rishi Singh, thank you for covering that. Now back to a couple of questions about yourself before we close this podcast. I ask all my faculty, what is your career achievement that you are most proud of?
Well, I have to say, Arshad, I've had the pleasure of mentoring and training a lot of people in the field, and all of them have done fantastic work. Many of them eclipsed me and professionally and in many ways. That to me is just a great honor. I'm just super happy to see them on podium or giving talks at major meetings or being cited in papers. That just to me is the most wonderful achievement of all.
No, and I tell you, I've seen your fellows and your relationship with your fellows. You're more of a friend than a mentor, and you're a friendly mentor, I'll call it. And all of them, I mean, many of them have done so well, right? Mark and Dilshire and Nathan and Yasha and so many others that you have trained that we all work with. So I think you should be very proud of them. Like we all train fellows, but having that level, global stage of presence because you train them is super important. Maybe they're there because you train them and other faculty at Cleveland Clinic and you kind of really prime them to be successful. So I agree. I mean, I think one thing I see in you is this commitment to educate the next generation. And I think it's going to be great as you start being the chair at Harvard. I think you will continue that and you will see a lot more output from your residents and fellows in the future. And then obviously too young to retire, but this is a question I ask everybody. How do you want to be remembered when you retire? I'll tell you how I remember you, but you tell us first.
I want to be remembered as being as much of an inclusive person as it can be. I think you're right. I've even beyond my fellows, faculty like you and others who I've worked with in the past. I just get tickled when I think about the opportunity to work with you all and to even contribute in some way, shape, or form. Being a team player is really what I've made my strides on, and I've enjoyed the contribution of each person. I mean, it's just so great, and I think that's what people forget sometimes is that it's really sometimes very individualistic. It feels like, but realistically, I've worked with so many people in this field, and they all help each other when you have times and needs and issues, and it's been great to have that camaraderie.
No, I think that very well said. I mean, I see you and I remember you as always polite and kind. I've never seen you having, a fit, we call it, or having ego issues. You're always very inclusive. You helped me a lot initially, being part of these activities where we educate our fellow physicians. Obviously, your legacy, Rishi, is that you're great to work with. You're a team player, and it's always a pleasure working with you because you're just a nice person, and you want everybody to rise with you. So that's my summary, and I think this is a great legacy to have. But obviously, too young to retire, Rishi. We expect a lot more contribution from you for our patients and for our field as we come up with the new treatments and obviously you're very closely involved with AI technology and other things that are going to be a reality in the future. Thank you, Rishi, for being here. I know you're very, very busy. I really enjoyed our excellent discussions, and I want to thank my audience for listening in. Thanks again, Rishi.
Thank you, Arshad, for the opportunity.
To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindicocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.